Good evening, everyone. Welcome to the Lung Cancer Living Room. I'm Danielle Hicks, Chief Patient Officer here at Patient Foundation for Lung Cancer. Today, as some of you may or may not know, we are going to be talking about two different disciplines, the medical oncology and radiation oncology space, and how these folks work together and coordinate the care and when it might be appropriate. So we're very, very excited to have Dr. Jonathan Riess and Dr. Megan Daly here from UC Davis.
Hi, I'm Jonathan Riess. I'm a professor of medicine at UC Davis Comprehensive Cancer Center. I take care of lung cancer patients, mainly from the medical oncology side, but we work in a multidisciplinary team.
I'm Megan Daly. I'm a professor of radiation oncology at UC Davis, and I specialize primarily in thoracic malignancies, including lung cancer.
Thank you both so much for joining us today. For those of you who might be more new to a lung cancer diagnosis and your own sort of experience in dealing with that diagnosis, I want to start with multidisciplinary care. What do we mean when we say that? And Jonathan, I'll start with you, and Megan, please chime in.
Sure. So I would just say that multidisciplinary care is critically important in terms of working to kind of get the best outcome possible when you are diagnosed with lung cancer. And so when we speak of multidisciplinary care, we really talk about your care team, whether it be, medical oncology, radiation oncology, surgery, pathology, who's doing the biopsy, interventional radiology, spanning dietitians, the whole team that comes together that have different areas of expertise that kind of coordinate care and work together in order to get the best patient outcomes, in order to try and cure patients of lung cancer. And so that's what we really mean by a multidisciplinary team. At UC Davis, we formed an integrated service line to kind of better coordinate care for our patients, to bring patient navigators and so forth, to really put the pieces together to get streamlined, timely care, to get care upon multiple specialists that work together, that talk to each other, to really get the best for our patients.
You mentioned that it's how important this type of care is, and we know that it doesn't happen necessarily everywhere, particularly in some of the smaller community, more rural areas where people are diagnosed. But lung cancer, as we know, in the last 15, 20 years has become incredibly complicated. It's a series of what I continue to call, whether it's right or not, a series of rare cancers, right, when you're looking at all the different subtypes. So can you talk a little bit about how critical it is that healthcare providers such as yourselves across the disciplines are talking to one another?
Well, it's incredibly important, as you mentioned, really starting from the moment of the beginning of a diagnosis being made, because there's so many important steps that have to happen along the way, that having integration from the doctors that you're meeting in the clinic every day, and also the ones kind of behind the scenes, the radiologists and the pathologists. So starting from the very beginning and figuring out what to biopsy so that we get the information that we need as quickly as possible and with as few procedures as possible. So that's where the role of something like a multidisciplinary tumor board is incredibly important. So starting from the beginning, having the whole team looking at a patient scan, thinking about what's the most efficient and effective and least invasive way to make the diagnosis that we need so we can come up with a multidisciplinary care plan. And then once that full diagnosis has been made, all the imaging's been done, the biopsies, all of the testing, then getting your team together again, because there are different modalities that can be used even in the same stage depending on somebody's preferences and other health issues. So really having, for example, a surgeon and a radiation oncologist who are very comfortable in the lung cancer space, who can talk about whether surgery or radiation might be better for a given patient. So there's just constant steps along the way where having all these different specialists is so critical in being able to kind of optimize care for each patient.
Yeah, it's really start to finish, from the moment of diagnosis to the completion of therapy, because we've really improved how we treat lung cancer, but along with that, it's gotten a lot more complicated. So to your point, every patient's different, and everybody's different in general in so many ways. But then even looking at the cancer itself, where do we, to make its point, where do we biopsy? Can we get enough tissue? Because we do, these gene profiling where we need enough tissue to sequence all these genes and do immune marker expression. Does somebody have something that's a kind of a game changer where we can match to a really effective pill drug, or is there immune, is the PD-L1 high where, most likely they're going to do really well with immunotherapy. And so from taking that jumping off point to, do we know exactly what the stage is? So, is integration of surgery with chemo the best? Is radiation with chemo and immunotherapy the best? So we could craft a kind of a personalized care plan, because with that complication, for example, we're giving chemotherapy and immunotherapy to a lot of patients before surgery now, and then potentially doing more immunotherapy and treatment after. So coordinating that, determining if that's the best course of treatment, you really need a care team that works together, that's well versed in how best to take care of patients with lung cancer with the most modern techniques and treatments.
Yeah, I think you make such a valid point. From really the moment that a lung cancer is suspected, like that's the moment where the details matter, right? Where the biopsies matter, where the tissue collection or the liquid biopsies matter, so that you can properly upfront diagnose and stage each patient. So let's assume all of that has happened perfectly, okay? And someone winds up in your office because they have been diagnosed, they have lung cancer, they've had the appropriate biomarker testing. What is the role, just in a general sense, of the medical oncologist?
I'm biased, so I'm going to say we serve a fairly important role in taking care of patients with lung cancer. So one component is, and what I tell patients, we look at two basic things. What kind of cancer is it, and where is it spread? But not only that, making sure kind of all these specialized tests are ordered, so like the gene sequencing, like the immune marker testing, so we could craft the best treatment plan. And oftentimes we're also the ones that kind of give the chemotherapy and the immunotherapy and some of these pill drugs that often make patients not feel so great, but in the end, with the goal of making patients feel better, live longer, and hopefully, as we strive to cure all patients with lung cancer, work towards that goal. Oftentimes we're coordinating care as all of us, in terms of radiation and surgery, and really pulling together the treatment plan in lung cancer cases that can be pretty complicated.
Yes, well said. Megan, what about you? What is the role of a radiation oncologist? Again, just sort of generally.
So we're a type of oncologist that uses radiation to treat cancer, and that can mean a broad range of things. There's settings in lung cancer where we are the primary treatment modality, where radiation is the only treatment modality that a patient's receiving. So, for example, early stage medically inoperable lung cancer, that's the most common one. Many of my patients have early stage medically inoperable lung cancer, and that's the only, in most cases, the only treatment modality they are receiving. So they see me for a consult, I treat them, and then I follow them for 5+ years after their care. Many times my patients are getting a combination of radiation and chemotherapy, so I'm jointly managing them with a medical oncologist like Dr. Riess, and we're treating their cancer while they're also receiving a drug therapy such as chemotherapy. So there's a role for that. That's typically in more of a locally advanced lung cancer setting. There's also a significant, and I'd say ever-growing role for radiation in metastatic lung cancer as well. If I remember correctly, that is on the schedule later, but we do play an important role there too. So kind of across the whole spectrum of lung cancer diagnoses, we're using radiation to kill tumor deposits, whether it's for cure in early stage disease or for symptom management, and a whole range of things in between.
I don't want to jump ahead in the agenda or what we're going to talk about tonight, but there tends to be a stigma, if you will, sort of associated with radiation therapy. So I want to kind of, quell any of those, the misinformation that might be out there about that. But before we do that, I think it's also really confusing for people diagnosed, particularly when it's been recommended that radiation is part of their therapy, to understand the different types. Some mean the same thing, some are different. Can you kind of walk through the different types of radiation therapy and how they're given?
Sure. And yes, radiation oncology for some reason is really in love with acronyms. We have a lot of acronyms that are probably overcomplicating things a little bit, but oftentimes they're different ways of describing the idea of using intersecting beams of photons to kill a tumor. That's most of what we do. We use a machine called a linear accelerator, and it's just a big machine that puts out high energy streams of photons. And at the very simplest, that can mean just a single beam coming out that would come at a tumor and hit it, but oftentimes we want to be more precise. So we want to have several beams coming from different angles that intersect on a tumor, and that's to limit any spill-off radiation to any of the surrounding organs, like the lungs or the heart. So some of the acronyms that you may hear from your doctor or see written in your chart, there's the idea of 3D conformal radiation, sometimes called 3D CRT, but 3D conformal radiation. And it's kind of what it sounds like. It just means several, at least two, oftentimes more, beams from different angles all coming together based on a CT scan planning, targeting a tumor. Then there's stuff that gets a little bit fancier. You hear about things called IMRT. That is an abbreviation for intensity modulated radiation therapy. And that basically means that we have some leaves moving in front of that beam of radiation so that you can kind of sculpt the dose around structures. So imagine you have a tumor in the middle of the chest and you want to treat that tumor and you really want to not give a lot of radiation to somebody's esophagus and heart and airways that are all really nearby. So you want that radiation to kind of wrap around certain structures and make this complicated shape. By having lots of beams coming from different directions and moving these leaves in front of it quickly, you can do that. There's a lot of fancy physics behind that I think is probably beyond my ability to describe to you all, and I doubt everyone wants to hear about it, but it works. There's other acronyms you hear about, SBRT. SBRT and SABRE are exactly the same thing. It was called SBRT initially, and then a couple of doctors, including my friend Dr. Liu down at Stanford, put a paper out saying we should call it SABRE, it sounds more interesting. It's exactly the same thing. And it's more or less what I've just described for IMRT, except you are giving really big doses of radiation over a small number of doses, usually between 1 and 5 treatments. And you are using really good technology, so you're making sure somebody is immobilized really, really well, so they're not moving. You make sure you have really good imaging so you can line that tumor up really well, and that you have a really good plan where the dose falls off really sharply so you can give big doses at a time.
And I think a lot of people think, well, how are they targeting particularly my lung lesions, maybe not a metastatic lesion, but my lung lesion while I'm breathing?
So there's different ways that we can take into account respiratory motion. And it's one of the things I find so interesting about thoracic radiation oncology, because we do have to deal with moving tumors. So first of all, most of the time when we're going to be treating a moving tumor in the chest, we start with doing something called a 4-dimensional CT scan. So instead of just doing a normal CT scan, we're doing a CT scan that's almost a video of your chest while you're breathing. So we can see how that tumor moves. Sometimes if that tumor doesn't move that much, we can just cover the entire area. So we're kind of covering that motion envelope that tumor is moving in. That's kind of the simplest way of dealing with motion. There is also the idea of doing what's called a breath hold. It's kind of what it sounds like. We have our patient hold their breath, we turn the beam on, and then about 15 seconds later we let them breathe, and we just turn the beam on multiple times and only treat the tumor while it's hanging out while they're holding their breath. That's a pretty effective way, and it works well. You can also use something called abdominal compression. We do this sometimes, and the idea is basically getting somebody to breathe less deeply so their tumor doesn't move up and down quite as much. And it actually works really well if you just put like a belt over somebody's abdomen. They'll take shallower breaths, and you can usually decrease the amount that tumor is moving. Then the fancier way of accounting for this is having a linear accelerator, so our machine that can turn off and on while somebody's breathing. So it can actually track that tumor and only turn on when it's in a certain space. We do have lots of high-tech and pretty effective ways of accounting for motion with breathing. It's one of the key things that we do with radiation oncology in the chest.
And I think that these are all really important ways of explaining some of the concerns folks have around radiation therapy is not only the amount of radiation they might be receiving, but what might be getting radiated that doesn't necessarily need to. We might be damaging healthy tissue, and this new technology minimizes those things.
It does, very much. So the risk to any organ next to a tumor is dependent on how much radiation that organ gets and how much of that organ actually gets that radiation dose. So the way your radiation oncologist looks at a plan and says, is this a safe plan or a somewhat safe plan or a dangerous plan, is, as a radiation oncologist, I spend a lot of time drawing on CT scans. So every single slice of a CT scan, I draw not only my patient's tumor, but I also draw all their normal organs on it. So their esophagus, their heart, their lungs, their spinal cords, in some cases their airways, their great vessels. And then for every one of those organs that's near the tumor, I go back after I've been given a preliminary plan, and I look at how much radiation is my patient or my patient's lungs getting. At this point, there are really good bodies of literature, a large body of literature on what is safe to give the lungs and what is somewhat risky and what is really risky. So I can look at that, say, what's the mean dose to their lungs, and various other metrics that are related to how much radiation is going to what proportion of the lungs, and I can give a pretty good estimate of what their risk is of developing a side effect from this, and that's true for basically every organ.
A lot of times patients will either call the helpline and Michelle can attest to this, and they're like, my doctor, my medical oncologist referred me to a radiation oncologist, and now I'm having this, and they want to do this like mapping, right? What do we mean when we say mapping?
We do pretty much all of our planning on CT scans, and we do need to actually obtain a new CT scan when you come in. And first thing all my patients say is, well, I already had 3 CT scans. Can't you just use one of the CT scans I've already had? And unfortunately, I can't, because I need to do a CT scan with them in exactly the position they're going to be treated in. So usually, for example, we want to get their arms above their head. We want to have their chest perfectly immobilized. And then, of course, we want to do that 4-dimensional CT scan, too, so we can see all the breathing motion of the tumor, of the organs in the chest. So we do need this new CT scan. And we oftentimes use either tattoos or removable ink dots that kind of serve as markers in space for where they are in relation to their scan. And so that what we call, the technical term is a simulation, but this mapping session, once we've done that CT scan and we've created whatever immobilization device we're going to use, it's oftentimes kind of a beanbag type thing. So someone lays down on this beanbag, we suck all of the air out of it, and they come back for their treatments, they can lay down back on this beanbag, and it's a way of kind of getting them back in exactly the same position. That scan is what then I go and spend a couple of hours drawing on the CT scan and mapping, and then working with some of the many technical staff we have that help with figuring out all the beam arrangements and all of the other complicated technical stuff.
Lung cancer, metastasizes to a lot of different places besides the lungs. So brain is often, mets are often challenging, and yet radiation is often used there, as well as in the liver, where fiduciaries are used. Can you talk a little bit about those 2 sites?
Yeah, absolutely. So when it comes to brain metastases, you're right. Most of the time, we do use radiation to manage those. There's some exceptions. There are some drugs that actually work very well for brain mets, osimertinib, for example. But in most cases, we're thinking about radiation when somebody has brain metastases. As much as possible, we try and use something called stereotactic radiosurgery, which is much like SBRT that I just talked about, it's a very focused, pinpoint way of targeting. And there's a couple of different devices that can be used to do that. Sometimes it's just the same linear accelerator that you've had all of your other treatment on. Other times it can be done with something called a gamma knife or a cyber knife. Those are really just other machines that are kind of doing more or less the same thing in terms of providing photons in a very focused way to those tumors to try and kill them. And we use radiosurgery because it really limits side effects as much as possible. But there are situations where we consider doing something more like whole brain radiation, and that would be when somebody has a large number of brain metastases or has tumor seeding throughout the CSF. And there's ways that we're trying to make whole brain radiation have less side effects as well. And the most recent one is the idea of treating the whole brain except for the hippocampus, which is the part of the brain that's responsible for short-term memory. So this is a newer thing. There have been multiple studies looking at this, and it does seem to help some of the side effects that we worry about with whole brain radiation. There are still risks with it, but it does help minimize that. I also tend to give the drug memantine most of the time, which has also been shown to help minimize those risks.
And this is one of the things that we work together on. I mean, talking about that multidisciplinary care team, there's a lot of, as Dr. Daly mentioned, there's a lot of new drugs, particularly targeted therapy drugs, like Dr. Daly mentioned osimertinib and EGFR mutated lung cancer. There's alectinib and lorlatinib and ALK fusion lung cancer. There's a number of drugs that are in clinical trials that appear to have exceptional kind of penetration across what we call the blood-brain barrier. So that's oftentimes where, when we talk to folks and have to talk about how best to treat lung cancer that's spread to the brain, finding out what kind of symptoms, how big they are, where the location is, where can somebody run into trouble if we don't do this type of stereotactic radiation, working together to say, hey, well, sometimes we could put patients on these pill drugs, not do any brain radiation and just follow things. There's also sometimes it can even shrink with immunotherapy versus, hey, it's near something where we really should, do the stereotactic radiation, make sure, things don't get worse before, and so these are the things we often talk about in a multidisciplinary team.
Yeah, and you were reading my mind because I wrote down here as Dr. Daly was talking, blood-brain barrier. So we know, and we talk a lot in the living room, in other programmatic areas and education pieces about metastatic lung cancer, for whatever reason, likes the brain, right? And I don't know why, and I'm sure you guys do, and we don't necessarily want to we don't need to get into why it might like the brain or what pathway might make it easy to get there, but can you explain what the blood-brain barrier is and why some drugs can get through and why some drugs can't?
In its kind of normal functioning state, it's to prevent kind of systemic toxins from affecting the brain. And so, that's something where we give certain drugs to treat cancer, including lung cancer, and some are better getting across this blood-brain barrier than others. And so certain drugs, like the ones I talked about, some of these targeted therapies, get across the brain really well, others not so much. And so that's something we take into account when we're, best designing, best coming up with the best way to treat a patient with lung cancer. And so that's one of the major factors that we take into account. And I would mention that sometimes when lung cancer affects the brain, that blood-brain barrier gets weaker because it's affected by the cancer. So some of these other drugs may still get across better. And these are kind of one of the things we take into account when we try to come up with the best treatment plans for patients.
Yeah. Sticking sort of in the brain metastases area, because it is such a common occurrence for a lot of folks, how often can you sort of spot treat the brain? Like, what might that look like before you have to have the conversation and say, okay, we need to now look at potentially whole brain radiation?
We can potentially use radiosurgery in many, many cases. I mean, I would say over the years I've been practicing, we have dramatically reduced our use of whole brain radiation. There's not an exact firm cutoff in terms of the number of tumors. It really does depend on the distribution of tumors in the brain, the size. I mean, I've heard of cases where people will treat 50 brain mets with radiosurgery. There's also the question of kind of how quickly are they appearing, and does it make sense to try and prevent new tumors from popping up with whole brain radiation? And so those are definitely discussions that someone would need to have with their multidisciplinary team. But we're routinely using radiosurgery rather than whole brain for patients with, say, 10 spots. And I would say when I was in training, it was more like 4 or 5. So we were definitely expanding it more and more and just trying to, really limit the side effects for patients. And the technology for doing radiosurgery has definitely gotten better as well.
Yeah, I think it's important, particularly for, again, those people seen in the more rural community centers, because I remember when cyber and gamma knife and all this kind of stuff were first coming out. I think I've got a little toy in the back somewhere that's a little mini cyber knife machine or gamma, I can't remember which one. But it was like 4 or 5, and that was kind of it. And we've come so far since then, thanks to people like you who were involved in the early studies and those who have continued to be part of the evolution of this. And I think it's really important to note, particularly if you are somewhere who is being potentially treated by someone who's just looking at that sort of original data and not sort of thinking bigger, that you are empowered to know that, educate yourself, and have those conversations with your healthcare provider.
And sometimes there's no way to get around giving whole brain radiation, but we try, if at all possible, not to do it, because people are living longer and longer with these newer treatments. If you give whole brain radiation early on, like I said, sometimes you just have to do it, but if at all you can find ways not to, then you could kind of try to prevent or delay those kind of, sometimes it can get neurocognitive side effects, months, years down the road. And so to try to prevent that as much as possible, we try not to do it unless we absolutely have to.
I would just add though, because some patients do end up needing whole brain radiation at some point, that I have had many patients who have received whole brain radiation and actually been highly functional afterward. It's very hard to predict who is going to have significant side effects, which is why we try and avoid it, because we can't really predict, but it is certainly not a foregone conclusion that you'll have significant cognitive side effects. Some people do not.
I just want to step back into earlier stage. And Dr. Daly, you mentioned radiation therapy being used for medically inoperable patients. Can either or both of you explain why someone might not be a good candidate for a surgical option and why radiation might be a good option?
As somebody who's not a surgeon and not a radiation oncologist, I'll start off by saying, we sometimes see patients, including in medical oncology, with early stage lung cancer, where for whatever reason, sometimes, when they get lung function tests, they can't lose that part of the lung, that much lung. Sometimes there's other medical issues where surgery is not an option. Sometimes patients don't want surgery. And so, under those scenarios, when there's smaller lung cancers, the lymph nodes aren't involved, these early stage type of lung cancers, it makes sense to talk with a radiation oncologist like Dr. Daly about doing focal stereotactic radiation to the lung cancer, where they have really good control rates and I would say cure rates. But we're always looking for ways to do better. So Dr. Daly also has an exciting clinical trial as well, looking at immunotherapy and the stereotactic radiation that would be best talked about.
And I love that. I think from the person diagnosed perspective, who has an early stage diagnosis and might think, well, I'm hitting the operating room, we're going to cut it out, that makes me feel good. They might feel a little disappointed to find that they're not a good candidate for X, Y, or Z reason. And so Dr. Daly, can you explain how and why radiation therapy is a good and potentially curable option for these folks?
This is the same idea that I was describing earlier, where we're just using high energy X-rays to kill a cancer. And this is not a new treatment at this point. This has been around for more than 20 years. The earliest studies using stereotactic radiation for lung tumors were in the mid-90s. So this has been widely studied, and we know that depending on the size and aggressiveness of the tumor, many of these patients are cured. Instead of taking the tumor out, we're simply killing the tumor where it is. And we now have very long-term data from some of these earlier studies, and these tumors many times do not come back. We typically only see the tumor grow back in that same spot in roughly 10 to 12% of cases. It depends a little bit on the size and the dose used and so forth, but many of the studies have shown about a 90% control rate at that spot where the tumor was. We do sometimes see recurrences elsewhere, whether it's in a lymph node or elsewhere in the lung or elsewhere in the body, but that is something you can also see after surgery. And that's one of the reasons that we are looking at whether it makes sense to, for select patients, add an immunotherapy agent as well, to try and see if we can just increase those cure rates a bit higher. And that was the study that Dr. Riess was referring to, which is being done through SWOG.
That's great. So anybody watching or anybody interested in learning more, reach out and we'll point you in the right direction.
Just want to clarify, so SWOG stands for Southwest Oncology Group. It's part of what we call a cooperative group where these are clinical trials done that are sponsored by the National Cancer Institute. And this is something that's open, I think, how many, it's got to be hundreds of sites.
Several hundred sites around the country.
Yeah, which is great. And we had, some of you might remember, Karen Van Camp was here. She flew out and she told us all about SWOG and what that means. And so it was a great meeting. So for those of you who missed that one, please go back to our library. And if you want to learn more about what the Southwest Oncology Group is up to, Karen's there to tell you all about it. So I want to talk a little bit about combination therapies, whether it's chemo radiation, a targeted therapy radiation, an IO radiation, combination therapies. How do you two and the collective multidisciplinary team determine when you are going to add radiation therapy to someone's treatment plan?
Well, I think there's kind of two scenarios. One is, we'll talk about where lung cancers spread to other parts of the body, like Rod mentioned, the brain and the liver and other parts outside of the chest and lymph nodes. And then there's other times where it's earlier stage, where there may just be the lung cancer that hasn't spread to anywhere else. There may be the lung cancer where it's spread to some lymph nodes that are near it or in the center of the chest. And based on that, we kind of do something we've done for a long time, which is find out what kind of the lung cancer is, because there's non-small cell, small cell. Within non-small cell, there's squamous, adenocarcinoma, different ways it looks under the microscope, and then how far it's spread. And that's where we use things like PET CTs and brain MRIs. And based on that, if it's sometimes where it's spread to lymph nodes, where surgery would not be as good of an option, like for example, if there's several lymph nodes in the center of the chest, we would talk about doing chemo radiation. So Dr. Daly would give radiation, I would give chemotherapy because it acts as a radiation sensitizer to make the radiation work better. And there's been clinical trials that show by doing that, patients live longer. And then after that, there was a trial called the Pacific trial in patients who finished chemoradiation, that when you give an immunotherapy drug after for about a year, that compared to not doing that, they live longer. Now, those are mostly patients who don't have these special mutations more associated with people who haven't smoked, like EGFR or ALK, where it's being studied the role of targeted therapies. And then there's scenarios where it's spread to other parts of the body, where sometimes, for example, where it's a metastatic lung cancer, where we in medical oncology would give one of these targeted therapy drugs like osimertinib for EGFR lung cancer, alectinib or lorlatinib for ALK lung cancer. And sometimes what we do is two scenarios that Dr. Daly can talk more about. One is there are some times where patients get great response to these drugs, and maybe one or two areas, hopefully it's not for some time, but a year, 2 years, sometime down the road, start to grow. And so there's good data for giving radiation to those and continuing the course of treatment. We're on to maximize each line of treatment to get the most amount of benefit. And then there's other scenarios too, where the cancer shrinks really well and is in check for some time, but there may be one spot that's just still not completely gone away. And do we come in and zap that? Because I think about it, there's all these, if we take off the drug, we know these cancers grow back. But there may be some cells hanging out there that kind of may be starting to develop some of these resistance mechanisms that help the cancer evade the treatment. So do we zap those, keep under control, still continue the targeted therapy, or in some cases immunotherapy?
When a patient is receiving systemic therapy, either chemotherapy, targeted therapy, immunotherapy, are you saying that sometimes maybe there's one or even two spots who might not be responding, but the rest of it is? I guess what I'm saying is, can a lot of the cancer be responding to the therapy, and then maybe there's one lesion that's just like, yeah, no, I don't think so. There's something different about that lesion, so that's when you might go in and spot treat them.
The theory is that probably there's a cell or two that developed a mutation that let them be resistant to the drug, while the rest of the cancer everywhere else in the body is responding really well. You have those one or two cells that developed some mechanism, and so they start repopulating, and pretty soon you have a tumor that's resistant, where all the rest of the cancer in the body is still sensitive to the drug. So if I come in and I give a high dose of radiation to that one spot using a very focal technique, the hope is that then that patient can just keep going on that drug and maybe stay on it for months or even years, and sometimes it works very well.
So how might we use radiation therapy palliatively, and what do we mean when we say that?
So radiation does have a big role in relieving symptoms from lung cancer too. And this is something we've been doing for many decades. And it's actually a really effective way of treating pain from bone metastases. Even with really relatively modest doses of radiation, and sometimes even over only a single treatment, you can see really high rates of pain relief. And it's just because you're shrinking that tumor that's in a bone, so it takes pressure off of it. So this is something that we do really frequently. I mean, I probably see at least a couple of patients a week for this indication. And oftentimes we can come back and do it again if the pain comes back in 6 months or 9 months, or even only 3 months. We can oftentimes come back and repeat that radiation, depending on what the location was and what the dose was. There's other symptoms that we can help with a lot. In lung cancer, for example, sometimes a tumor is in a bad location and it causes bleeding from an airway. And radiation is really good at getting rid of stopping that bleeding. Now, sometimes the pulmonologists are good at doing that too, and we oftentimes talk to them first, but radiation within a couple of days can usually stop bleeding. We can oftentimes help if a tumor grows into an airway and is blocking that airway. We can oftentimes open it up. So there's a lot of ways that we can use radiation to pretty quickly relieve symptoms. Oftentimes for my patients, a lot of it is, they could take pain meds instead, but they don't like the pain meds, they have side effects, and oftentimes the radiation has far fewer side effects than the pain medications that they would end up taking otherwise. So that is a big role for us as well.
How do you guys coordinate this care? How is the patient navigated, I guess, through all of this? Is it navigators? Do you guys have navigators?
Yeah, well, as part of our new integrated service line, we now have patient navigators. That's something we've wanted for a long time, and finally have over the past several months, which has been really great in terms of helping to coordinate care, in terms of appointments, scheduling, timing of things, like getting the scan before seeing us to make sure we have everything we need to make the best decision for the patient in a timely manner.
Yeah, I think it's interesting, and I only ask because I know that that's not always the case, where this care is coordinated and there's this understanding between the two of you who are treating potentially the same patient. And example might be a patient who's receiving chemotherapy, chemo radiation at the same time. And all of a sudden they find themselves in the emergency room because of X, Y, or Z, right? And now the rad-onc's like, why aren't you showing up to radiation? And the med-onc might not, there's nobody knows that this person has been in the hospital for 4 days, and they're getting sort of like these, emails saying you missed your appointments. I think that happens a lot. And so this sort of integration approach is fantastic, but it doesn't always happen. And so in an instance where maybe that's not happening, how can the patient or a care partner of a patient maybe help to coordinate those efforts to let folks know?
For example, if one of my patients ends up in an emergency room that's not UC Davis, we do, luckily I have some really good staff in my department, so the first thing if somebody misses their appointment is let me know that they've missed their appointment. And I have a great nurse who will then start sleuthing around to try and figure, first call the patient or their family and ask. But I'd say the first thing the patient could do is just ask one of their family members to call the radiation oncologist's office and let them know, and then hopefully that doctor can let all their other doctors know that they're in the hospital.
Yeah.
And I just want to emphasize in general for patients and caregivers, and there's a lot of things with all this multidisciplinary care that we talk about that could be so confusing, so many moving parts. If you're unsure about something, call, message your doctor, message EMR, call, the case manager or nurse, reach out to somebody. If you're unsure, make yourself sure.
Yep.
We'd much rather get 2 messages than 0.
Yeah.
And never mind getting a message from a patient telling me something I already knew. It's still helpful.
Yeah, and just to elaborate on that, because this is a real big sweet spot for us at GoTo, based on current guidelines, which as a patient advocate I don't think are enough. I think it's a starting point, how we are screening people now. There's roughly in the United States 16 million people based on qualifying criteria that should be getting annual screening. Depending upon where you're looking at screening in this country, it's anywhere between 4 and 12% of those people are actually utilizing this life-saving screening tool. So if anybody wants to know more about what screening criteria are, please reach out to us, because we will help you not only determine whether or not you qualify, but help you find a screening center near you. The research and the studies being done on this right now, particularly in, is there a genetic sort of propensity for people to get lung cancer? Alchemy, who I think a lot of you know is our sister organization, the Daly Lung Cancer Medical Institute, did a study several years back that was just published about a month ago called Inherit, looking at T790M, which was thought originally to be a resistance mutation to the EGFR, but has found through this study a germline sort of like piece to it. So planning on furthering that study to hopefully help open up screening criteria for those that don't necessarily have a smoking history.
So, I think consistent with the theme of tonight, kind of a multidisciplinary care team is essential. We have patients are living longer with lung cancer, but in order to get to that point, things have become more complicated in terms of getting special molecular testing, immune marker testing, imaging studies, coordination between radiation oncology, medical oncology, surgery, everybody. And so that's having that team and that team that works together is critically important.
Basically, for every lung cancer patient, there is a big team of people working both in front of the scenes and behind the scenes to try and kind of optimize your care. And so it's 8 or 9 specialties, really, when it comes down to it, who are all working together to figure out the best treatment for each patient.
This, I think, has been a fantastic conversation. There's a couple of things I want to go over. I want to give a huge thank you to our panelists. All of you in the room, all of you watching live, all of you who will come back and watch post live, and I would be remiss in not acknowledging those who provide the support so that we can bring this programming to you every month. So Amgen, AstraZeneca, Bayer, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Janssen Oncology, Merck, Mirati Therapeutics, Novocure, Novartis, Regeneron, Sanofi, and Takeda. Thank you very much for continuing to support this important programming. We will see you all next month, and until then, let's go have some coffee crunch cake.
So I'll be brave if you're brave. I'll be brave, but only if you're